The following audio is from a two-part presentation with Dr. Leonard Calabrese. This audio is part of a certified educational activity titled Recent Advances in the Management of Rheumatoid Arthritis, a clinical update from Washington, D.C. To access the entire activity and complete the post-test, please go online to www.peerreviewpress.com/SRH. A printable monograph, slides, practice aids, and other features are also available.
Diagnosing rheumatoid arthritis early in the disease is ideal and becoming ever more important because we recognize that the treatments that we have work better in patients with early disease than patients with established disease. Guidelines by the American College of Rheumatology and EULAR state that using new biologic medications in addition to more aggressive dosing of traditional medications is the optimal way to achieve results. And of course, we're all encouraged and moving ever toward a treatment to target strategy. But before we start, let's just get our nomenclature on the same page. So we talk about DMARDs. We know these are disease-modifying anti-rheumatic drugs, and we divide them into those that are synthetic and biologic. But now we have subcategories. The conventional synthetic DMARDs. Those are our old friends, Methotrexate, sulfasalazine, and leflunomide. But we also have a new term called targeted synthetic DMARDs. The first JAK inhibitor, which I like to call Jacatinib, is Tofacitinib in this category. There's many on the way. Biologics up till now have been biologics, but now we call them originators. Those are the drugs that already have patent, have been through the standard approval process, and you can't look at any journal or any educational venue recently without appreciating that we are now just figuring out how to use biosimilar DMARDs in our practice. With that introduction, let's take a dive into some abstracts. I picked out some that I feel are particularly high impact that tweaked my interest. Let's go. So the first abstract I will talk about is the Accelerate trial. This is presented by Dr. Fleischman, switching between Certolizumab Pegol and Adalimumab after primary anti-TNF failure. This was a very bold study. Really asked the question that saying after we apply our treat-to-target guideline in patients with RA, and we have required a TNF inhibitor and they failed a TNF inhibitor, is there any difference between switching to one of two different TNF inhibitors, Certolizumab versus Adalimumab? To be a TNF incomplete responder was primarily on the basis of efficacy, some toxicity. And the other interesting aspect of this trial was that there was no washout period. So when you switched to a TNF inhibitor, you didn't wash out from one to another, just went at the next dosing phase. It was 104 weeks, blinded to the investigator, parallel group, head-to-head superiority study, comparing week 12 and week 104 for efficacy and safety of these agents. At baseline, over 450 patients were randomized to Certolizumab and a virtually similar number to Adalimumab. Of the 122 patients who wound up switching, in other words, they started the first TNF inhibitor and didn't meet their target, at week 12, 65 were Certolizumab non-responders and 57 Adalimumab non-responders. There's a lot of data in this abstract, and I'd like to cut to the chase for you. While sponsors of this study were hoping for significant differences, the final answer was that they were both pretty comparable. Good response rates, over 50% in each group, and while small numerical differences can be seen between these, there was nothing of statistical significance. One of the important conclusions of this study was that efficacy can be achieved using a second TNF inhibitor after a primary TNF inhibitor, because everything else that we look at for the most part are observational trials. This was randomized and controlled. The second thing that was found in this setting is that a washout period appeared to be very safe. In other words, not having a washout period, just going with the next scheduled dosing of a new agent. And so I thought that this was impressive. So a bold study, not much difference between the second TNF inhibitor, just like we can say that there's really not much difference between original TNF inhibitors. Another abstract that I looked at was continuation versus withdrawal after reaching low disease activity 1 year after certolizumab pegol in DMARD-Naive patients with early and progressive active RA. So this is kind of an interesting study because this is on the minds of all rheumatologists. We get patients to our target, which can be low disease activity or remission, and it is sustained. And the discussion continuously rises up, is that should I continue all these drugs? Can I cut the dose down? Should I discontinue these drugs? So this patient population looked at a large number of patients. They asked this basic question, but the metric that they used, again, was low disease activity. And the primary endpoint was rather complex. They combined dose reduction and dose discontinuation of certolizumab into one group and comparing it to the discontinuation. So on the basis of numerous statistical limitations, the primary endpoint of this study was not observed. But I will show you something interesting in this graph. As you can see, to get to the point of time where you made this dose reduction or dose continuation, you had to be in sustained low disease activity between week 40 and 52. That's why everyone's at 100%. The red line are the people who had reduced dose frequency, in other words, a tapering. The blue line were people that kept on certolizumab at a standard dose. And the gold line was those who stopped their drug. By the next 52 weeks, about a third of patients fell out of target when you discontinued the biologic. Looking at the glass half full, the dose reduction group does not really look palpably different than those that kept on the same dose. There's not much enthusiasm for eliminating the dose, but there is growing enthusiasm for reducing the dose. If we now look at the effects on radiographic progression, there's really not much difference between stopping, reducing, or continuing the standard doses, so this is making us feel pretty good, whereas methotrexate alone, by extrapolation, is progressing at a greater rate. So while the study did not achieve its primary endpoint, it did show us that a higher proportion of certolizumab patients achieved low disease activity and radiographic stabilization compared with those that stopped. I'm telling you that dose reduction was looking pretty good to me, and this also told us a little bit about radiographic progression as well. Go back to the abstract and drill into it. The next abstract is a comparative effectiveness of Tocilizumab, the first-in-class IL-6 receptor inhibitor monotherapy, versus TNF inhibitor and low-dose methotrexate, 10 milligrams or less, in patients with RA who have had prior exposure to a TNF inhibitor. So consider the setting in your practice. You have a patient who has worked their way to a TNF inhibitor. Things are not going good by your assessment and the patient's assessment. You're not at low disease activity or in remission or an untoward effect from this agent. And now there's a switch about to occur. Can we use Tocilizumab monotherapy, a drug that's already been shown to be more effective than methotrexate monotherapy and more effective than TNF monotherapy, but we're adding on adjunctive methotrexate, not optimized methotrexate, but 10 milligrams, the way that we often use for pharmacokinetic purposes. So what did we find out of this study? Well, as it turns out, and I'm giving you the numbers here to look at, that regardless of whether you failed one or more than one TNF inhibitor. Both of these strategies were pretty decent. Both groups had improvement in CDAI and functionality by MHAC, and about 1/3 achieved low disease activity over this 6-month period of time. In adjusted models, both of these appeared to be pretty comparable, no palpable differences. So what do we take away from this? Well, after a patient has failed a TNF inhibitor, a second TNF inhibitor with low-dose methotrexate is a viable option. But also, getting rid of methotrexate and being on tocilizumab monotherapy is also an option. And this warrants further study in a larger population. So I thought that this was a pretty cool study. The next study I'd like to show comes from a German registry examining the safety of tocilizumab, again, the IL-6 receptor that is the first in class that we've had for a number of years right now, across different ages. I think this is important because certain in-class complications of this drug come to mind, such as diverticulitis and bowel perforation, which age clearly is a comorbid factor of great risk. Not only do patients with elderly have more diseases, but in general appear to be on more drugs. So I'm showing you a graphic analysis across age groups. So this is taken out of a large population database in Germany, and you don't have to be a statistician again to see that despite higher disease burden at baseline, shown from core elements in the abstract, patients who were considered elderly, and this was greater than 65 years of age, benefited to the same extent as younger patients without any increased risk of serious infections, discontinuations of tocilizumab due to adverse events, or gastrointestinal perforations. So this is an important study, adding to our knowledge of IL-6 inhibitors. We have 2 new ones waiting in the wings, and I'll tell you a little bit about some of these other studies coming along. So let's stick with the tocilizumab data. IL-6 inhibitors, first in class agents for rheumatoid arthritis, and we're drawing upon 2 previously published studies, Ambition, where patients who are methotrexate naive or had discontinued at less than 6 months or greater than 6 months previous were randomized to methotrexate or a tumor necrosis factor inhibitor using full dose 8 milligrams per kilogram tocilizumab. The other trial, called ADACTA, took biologically naive patients who were intolerant or inappropriate for methotrexate and randomized them tocilizumab or adalimumab subcutaneously every 2 weeks. So we've known about these studies for a number of years, but this is drilling down into the patient-reported outcomes. This is done and reported by Vibeke Strand, who has taught us so much about patient-reported outcomes. And here you can see we're looking at patient globals for pain, fatigue, looking at SF36, looking for vitality, role of mental and social functioning. To summarize a very dense data, both of these studies showed that consistent with the CDAI responses, which were used as the kind of the arbiter of this, tocilizumab monotherapy resulted in more patients achieving these minimal clinically significant cutoffs for multiple patient-reported outcomes compared with either methotrexate or adalimumab monotherapy. So it adds to the weight of our knowledge of this class of drugs. Speaking of this class of drugs, as most of you are aware, there are 2 drugs in very late clinical development programs that have filed for approval by regulatory agencies. One is called Sirukumab, which is a human monoclonal directed against IL-6. Remember, the first-in-class drug is directed against the IL-6 receptor. The other is Sirukumab, human monoclonal against the receptor. The Sirukumab development program is rich and large. There are multiple SIRROUND trials. I'm just focusing on SIRROUND-T, which evaluated the efficacy and safety of Sirukumab in patients with RA who were refractory or intolerant to anti-TNF agents. If you think about the guidelines, the recent ACR guidelines says if you fail conventional DMARDs, which you're encouraged to use, methotrexate having primacy in most of our practices, we can then go to a biologic, and they don't really specify biologics, but rheumatologists talk with their feet, and TNF monotherapy is used by most of us. That second switch after TNF is a matter of great debate. 5 years ago, we switched to TNF, and we switched to another TNF. Now most of us either switch to another TNF or immediately go to another class. This large study of over 800 patients were randomized to look at efficacy and safety. This is a pretty tough population of patients, with nearly 40% having taken 2 or more anti-TNFs. And that's a high hurdle to look at. The majority, 3/4 of these patients were on methotrexate. When you look at the data for this result, the primary endpoint being ACR at week 16, you can see the 100 milligram and 50 milligram dosing, and there's a kind of an odd dosing schedule here. The 100 milligrams Q2, the 50 is Q4. This is not approved, so we don't know what the approved dose is, but they were both very effective at reducing disease activity. And secondary endpoints, which included HAQ-DI, ACR 50, and DAS28 remission, also were very impressive across the board. So in this difficult-to-treat population, both Sirukumab 50 and 100 reduced signs and symptoms, even in patients who had failed 2 or more biologics. What I'm not showing you are the safety profiles, and I will just make an editorial comment now about all the data that I've seen from the new IL-6 inhibiting compounds. They all appear to be consistent with the class that we have known and have experience with in terms of their effects on liver, lipids, serious infections, and bowel. So it's an exciting group of drugs, adds to the diversity. We'll wait and see more data as it moves to regulatory approval. Jacutinibs are hot in rheumatoid and now moving into SPA and PSA. And the next drug in line for regulatory decision-making appears to be the JAK1 inhibitor, Baricitinib. It's a potent QD drug that has a rich development program, very large program. And I will just focus on a post hoc analysis of 2 of these studies, the RA Build and the RA Beam studies. Both of those looked at patients who had conventional DMARDs. One population, the Beam study, more prognostically severe than the Build because they had very high CRPs and baseline structural damage. So the purpose of these studies was to actually look at the effects of these prognostic factors on response to Baricitinib. So in both of these studies, we already know that the primary objectives were met for both studies. The clinical efficacy of Baricitinib 4 milligrams over placebo at week 12 and the percentage of patients with radiographic regression in the Beam study were similar, regardless of how many adverse prognostic markers were present or the use of concomitant glucocorticoids. And so as we kind of position this drug in our armamentarium, we can see that even the more severe patients appear to be responding to it over time. The next study is looking at the effects of Baricitinib in elderly patients with moderate to severe RA. I think this is important because the Jacutinibs are a little bit, they give us pause. We're not inhibiting a single cytokine. We are inhibiting intracellular hubs of multiple cytokines. So the BUILD and the BEAM study, which I just told you about, now is asking a question to evaluate efficacy of safety in an elderly population. So in these two studies, there were 249 patients greater than 65 that were randomized. I will tell you that they met their efficacy endpoints, including core indices and function, and there was no difference in the response between those that were older or less than 65. Now, if we look at more select parameters in terms of safety, which is shown on this graphic. On the left, you have placebo. On the right, that you have the Baricitinib group, less than 65 and greater than 65. So you're actually looking at discontinuation due to adverse events. You're looking at serious adverse events, serious infections, cardiac disorders, all of which are of concern. Well, as you can see, if you just look at serious adverse events and serious infections, there is a uptick of events in the elderly, but these are relatively small and certainly within the range that we expect in biological agents that have been compared in these types of trials. There was no cardiac signal, and overall, I think that the results were more or less as expected. But to me, my editorial comment, I was actually quite comforted by this, very similar to the Tocilizumab older age group that we had looked at a few abstracts ago. Continuing along with Baricitinib, this next abstract examines the efficacy and safety of switching from Adalimumab to Baricitinib. Now, previous studies, the RA-BEAM study, has already demonstrated that in TNF-naive or inappropriate patients, that Baricitinib is superior to Adalimumab monotherapy. But a more relevant question, or at least as important a question, is that what is the data that we would see if we were on Adalimumab and then made a switch to Baricitinib. So the objective was to assess efficacy and safety in a population of patients who were previously treated with Adalimumab and then switching to Baricitinib. And this came from two studies, the previously mentioned RA-BEAM and a long-term extension study called RA-BEYOND. This table shows the efficacy through week 24 in the RA-BEYOND, and it compares Baricitinib to Baricitinib versus this switching group of Adalimumab to Baricitinib. The variables that are being displayed include these core ACR 20/50/70s, CDAI, SDAI, and a functional parameter in terms of HAC. And as you can see, that switching from Adalimumab to Baricitinib without Adalimumab washout, so there was not a big delay, just next dosing, start this new drug, was associated with improvements in disease control during the initial 12 weeks post-switch without an increase in overall treatment-related adverse events, serious infections, or other signs of worsening. So I think that this adds another layer of information about this jacutinib, that it is effective very early up front as monotherapy, and also will probably have a place in a switching strategy. As we kind of close in on some miscellaneous topics, you couldn't cover that meeting without running into biosimilar data. And I show you three biosimilar trials, one CTP13, biosimilar infliximab, SB4, a biosimilar Etanercept, and SB5, biosimilar adalimumab. The reason I put these three studies in is that the questions that linger around biosimilars are not whether they're efficacious. I don't know anyone who has seen any of these studies and critically appraised them. They look identical, if not biosimilar. And that's not a doubt in many people's minds. The real question is, what will happen in the switching strategies? The simple switch is you're on the drug, the originator drug, and then the doctor switches you to the biosimilar drug. What will happen to those patients versus comparing them both de novo in a naive population? So these 3 studies had some element of switching, simple switching. I'm not talking about interchangeability, flip-flopping from drug to drug to drug, but a single switch. And the data from these are quite clear that not only was efficacy and safety demonstrated, but immunogenicity profiles were highly comparable, no matter which way these switches were directed. So one more notch in the biosimilar belt to reassure us that as these drugs are introduced, at least in this fashion, switch appears to be a benign event. I think it's really important. This abstract is on a very important topic that explores maternal fetal health in rheumatoid. And the question that's asking is quite simple. In offspring that are born to mothers with RA, what is the risk of serious infection versus the general population? And adding to that a layer, another question, is that what if the mother was on a TNF inhibitor at some point in time during this pregnancy? Does that add risk? I think it's a really important biologic question. Most of the TNFs will have some maternal fetal transmission. You know, there's this interesting data showing that Tocilizumab may be lesser risk in that area, but no one can say no risk for anything. This was a very interesting study from this PARIS database, meaning pregnancies in RA mothers and outcomes in offsprings in the United States. It looked at a fairly large cohort of pregnant mothers over about a 4-year period of time. They compared the infection rates versus the general population. We've already known or believed that children born to RA mothers have an increased risk of serious infection. Mothers have been on prednisone, the mothers have an inflammatory disease. But this study was really unable to establish with the confidence intervals generated from a large number of patients that being exposed to a TNF during pregnancy, including all the way up through the 3rd trimester, increased that risk. So I will take that away as I counsel my patients. As we're coming to learn from other data that having active RA is probably a greater risk to all health than having treated RA. And so I think that this is a pretty important bit of data. The last abstract that I would like to discuss with you is a long-awaited one. We have known since the introduction of IL-6 inhibitors that one of the biochemical adverse events is a elevation of LDL, a smaller elevation of HDL, the LDL-HDL ratio moving in the wrong direction. We know from the package insert that we're supposed to monitor lipids and assess them pre-therapy, and thus there's been a great concern. On the one hand, traditionalists have said these lipids are going the wrong way, we should be doing something about it. On the other hand, studies on the function of lipoproteins in these patients have shown that there is palpable and significant improvement in the efficiency of lipoprotein function, in particular LDL and HDL attendant with IL-6 inhibition. But, you know, the acid test is, what does this do to cardiac events? It's a difficult question to address, and this study has been designed to do it. So this is a large study of over 3,000 patients that were randomized to Etanercept and Tocilizumab. The primary endpoint was looking at MACE events. Looking at the number of events in a 3,000-person study, you're talking about difference in cardiovascular deaths of a single person, non-fatals, MI, 3 people. The numbers are small. The hazard ratio of Tocilizumab over Etanercept is 1.05, and the confidence intervals are as wide as an ocean, 0.77 to 1.43. Based upon these data, I don't think that any of us should be worrying that Tocilizumab versus this TNF inhibitor are palpably or clinically meaningfully different. And this was a very tough study to do. There's a drug dropout and many methodologic problems along the way. To me, this is one of the most important safety trials done. It shows that this question of palpable increase of adverse events is over in my mind. And I think that now we can start drilling in and looking at some of these small differences here and seeing if any of these are meaningful and whether we can exploit the use of this drug in cardiovascular disease. I've given you a whirlwind tour looking at some existing data on old drugs, some new drugs waiting in the wings. We've looked at efficacy, quality of life, and safety. I think that the pipeline is rich. We're going to be seeing new drugs all the way through the next year and beyond. I hope to be able to bring you more progress from the next big meeting to be held in Madrid in June. Thank you.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening to this activity. To view the rest of the CME activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/SRH. This activity is supported by an educational grant from Genentech and UCB Incorporated.